Science in Public Health from Khyber Medical University, Peshawar, Pakistan. I have passed my NCLEX examination in 2024 in Texas Board of Nursing. Today we will discuss some important concept of arterial blood gases, which is one of the important tools used in clinical medicine to assess a patient's respiratory status, oxygenation, and acid-base balance. These are some of the table of contents we will discuss uh, about the objectives, definitions, acid-base regulation, acid-based imbalances, respiratory and metabolic acidosis and alkalosis, arterial blood gases, specimen collection and interpretation, goal of care and intervention, summaries and references. These are some of our objectives to understand the use in mechanical mechanism of acid-base balance and pH homeostasis in the body, to understand the etiologies and manifestation of various acid-base imbalances, metabolic and respiratory acidosis, metabolic and respiratory alkalosis, to understand compensatory mechanism of acid-base imbalances, to use critical reasoning and step-based analysis to determine acid-base imbalances and compensatory status, to treat acid-base balances in use of the pharmacological and non-pharmacological intervention to monitor the patient-associated complications. If we can simply define the acid, acid defined as it release hydrogen ion in solution. Stronger acid release more hydrogen ion. Base accept hydrogen ion in a solution. Stronger base bind to hydrogen more easily. These are the scales which we measure our pH. It starts from the 1 to the acidic environment, 14 to the basic environment. The recommended and the average pH is 7, which is normally for water, and the acidic environment, which is most commonly present in battery acid and lemon acid, and the seawater, chlorine, bleach, ammonia, it go toward the basic. pH and hydrogen concentration have an inverse relationship. When the pH goes up, the hydrogen ion will go down. When the pH go down, the hydrogen ion will go up, and it both have inverse relationship. These are the equation which is commonly used for the blood gases. For example, we have CO2 in water which combine and form carbonic acid, and it make sodium bicarbonate and hydrogen ion which when it broken down. Hydrogen ion level and carbon dioxide level are directly related. Therefore, an increase in one results in increase in other results. Increase hydrogen, increase CO2, and decrease pH are positively correlated. Increase bicarbonate and decrease hydrogen and increase pH are positively correlated, as we discussed earlier that bicarbonate increase the pH level because it's basic, and hydrogen ion it decrease the pH. The more hydrogen ion, the lesser the pH level. We have one of the important mechanism which we call as compensation. It is a process in which the body attempts to correct the changes in blood pH. We have two compensatory mechanisms. The one is the kidney and the other is the lungs. The lungs are more active due to the neurological supply. For example, we have medulla oblongata which activated earlier and it compensated the whole process more rapidly. Comparatively, kidney, it take hours, and respiratory condition it take minutes, seconds to minutes. If we discuss about the pathophysiology of acid-base regulation, buffers are solutions that prevent major pH shift by removing or releasing hydrogen ion. We have bicarbonate and carbonic acid buffer system. It neutralizes HCl to carbonic acid in salt, it preventing making a large changes in the blood pH. Carbonic acid is broken down into water and carbon dioxide and excreted in the body is shown in the below equation. For example, we have strong acids such as HCl and sodium bicarbonate Na2CO3, and it make when it dissolve it makes sodium chloride and weak carbonic acid. We have also protein buffer system, that is intracellular and extracellular. In intracellular we have hemoglobin, and extracellular we have the and extracellular are albumin. If we talk about the intracellular hemoglobin, it is the most important intracellular buffer. Cellular protein containing amino acid residue, especially histidine. The function of intracellular hemoglobin, it binds excess hydrogen ion when the pH decreases. It also releases hydrogen ion when the pH increases. It also helps to maintain the intracellular pH stability. If we talk about the extracellular protein, this is the albumin. It have the major extracellular protein buffer, plasma globulin. It function buffer change in the blood and extracellular fluid. It contribute to the body overall acid base balance through less effectively than intracellular protein. If we talk about the phosphate buffer system, the sodium and other cation combine with the phosphate and act in a similar manner as bicarbonate system. Buffer capacity, it is the ability to resist the change in the pH is not unlimited to once too much acid or base is added to become overwhelmed in the change in the pH occur, because it is a slowly process and it take time to compensate the process. For example, we have the sodium bicarbonate. The kidney help to absorb or excrete in the urine to neutralize the acid. If we talk about the pathophysiology of acid-base regulation, we have the important element such as CO2. It forms carbonic acid when combined with water. The respiratory system regulates carbonic acid by eliminating or retaining CO2. When the body retains CO2, it decreases the pH level because CO2 is highly acidic. In acidic condition, mostly in respiratory condition, the CO2 will increase. But in compensatory mechanism, CO2 also help to increase the to neutralize the base level. In acidosis condition, increased hydrogen ion or carbon dioxide concentration stimulates respiratory center. We have respiratory center such as medulla oblongata. It regulates the rate and depth of respiration increase. It increases the lung ventilation, elimination of carbon dioxide from the body, and carbonic acid level fall, bringing pH back to the normal range. In alkalosis condition, decreased hydrogen ion, a carbon dioxide concentration depress respiratory center. It decreases the rate and depth of respiration. Carbon dioxide will retain inside in the body, combine with water to restore carbonic acid level and bring pH back to the normal level. If we shed a light on the renal system, kidneys also play a significant role in long-term regulation of acid-base imbalance. It have main component of bicarbonate movement. Bicarbonate is reabsorbed when the hydrogen level are high and excreted when hydrogen level are low. Bicarbonate are basic in nature. When the body have the low pH, bicarbonate will help to increase the pH level because it basic. Acid formation use the phosphate buffer system. Hydrogen bind to phosphate ion to create an acid which can be excreted in the urine. We have also the ammonium component. Hydrogen ion follow ammonium byproduct of protein and both are excreted in the urine, and it also help to increase the pH level. Acid-base balance, how it regulate inside in our body. When the problem arises the cause an imbalance, the body will initiate a regulatory mechanism to bring the pH back to the homeostasis. Each regulatory system cannot compensate for its own balance because it has some defects or some problem. Lungs cannot compensate for problem caused by lungs because there is some behind issue which going on. It cannot compensate itself. The other organ, which is kidney, it will help to compensate the lungs, and kidney itself cannot compensate for their own problem caused by kidney. We have a regulatory system such as lungs. We talk about that it responds quickly to metabolic pH changes. In acidotic condition, the rate of depth of respiration increase to exhale carbon dioxide. In alkalotic condition, the rate and depth of respiration decrease for the body to retain carbon dioxide. Regulatory system, kidney respond to respiratory pH changes. Correction take longer time. It required hour or day for compensation to happen, but it is stable. In respiratory condition is for the short time, and the kidney help to maintain the environment for longer time. In acidotic state, excess hydrogen ion will be excreted in kidney. In alkalotic state, kidney will retain bicarbonate. If we look into the minute level of cellular structure, normally the potassium present inside in the cells and hydrogen ion present outside of the cells. We call it extracellular space. When the body is in an acidic condition, potassium ion move out of the cells and make room for the hydrogen ions. Potassium will move outside and hydrogen ion will enter inside because potassium will leave a space for the hydrogen ion. The potassium level will be increased in blood. We call it hyperkalemia, and the pH will go up. If we look to the alkalosis environment, and the alkalosis environment, the potassium will move to the inside and hydrogen ion will move outside. In this condition, the potassium level will be low in blood. We call it hypokalemia, and the pH level will also go down. Acid-base imbalance, we have two conditions. One is acidosis and the other is alkalosis. And then we have two components. One is respiratory acidosis, respiratory alkalosis, metabolic acidosis and metabolic alkalosis. There are some reasons which cause respiratory acidosis. The first one is severe asthma. How it causes respiratory acidosis? Airway nerve traps CO2, causing CO2 retention. In emphysema, damage alveoli, reduce CO2 elimination. In hypoventilation, inadequate breathing lead to decreased CO2 excretion. Pulmonary edema, fluid in alveoli impair gas exchange and CO2 removal. Pneumonia, inflamed fluid fill alveoli, reduce ventilation and CO2 clearance. Brain trauma, damage to the respiratory center, decrease breathing and rate depth. The last one is CNS depression. Drugs, for example, we have opioid and sedative drugs like morphine, ketamine, and many more opioid and sedative drugs, midazolam, barbiturate. It suppresses the respiratory center, causing hypoventilation and CO2 retention. If we talk about the respiratory alkalosis, the first one we have the fever. It increases the respiratory rate, causing excessive CO2 loss. The second one is hyperventilation. Rapid deep breathing removes too much CO2 from the blood. The next one is hypoxia. Low oxygen stimulate increased breathing leading to excess CO2 excretion. Overventilation, excessive ventilation removes CO2 faster than it produces. Pain can stimulate hyperventilation, causing CO2 loss. Acute asthma exacerbation, patient often hyperventilate due to respiratory distress, lowering CO2 level. If we talk about the clinical manifestation of respiratory acidosis, the first one which is common, that is neurologic. Neurologic condition, the headache is most common due to the patient CO2 retention. Disorientation, dizziness in coma. In respiratory condition, hypoxia is common. Hypoventilation, if there is respiratory issue, lungs are unable to compensate. In cardiovascular, decrease the BP because it causes vasodilation due to the smooth muscles activation, and it also causes ventricular fibrillation due to hyperkalemia. In acidotic condition, the potassium mostly move to the blood and it causes ventricular fibrillation when the potassium goes to the heart. And there is also a flesh skin. Neuromuscular seizure is also common. There is involuntary brain signal move inside in the brain. The clinical manifestation of respiratory alkalosis, neurological confusion which is common in both respiratory acidosis as well as in the respiratory alkalosis. Lethargy is also common, light headache. In respiratory condition, hyperventilation is common. If there is a respiratory issue, lungs are unable to compensate. In GI, epigastric pain, nausea and vomiting is also associated with the respiratory alkalosis. In cardiovascular system, tachycardia, dysrhythmia associated due to hypokalemia. In neuromuscular, numbing, tingling, tetany, hyperplexia and seizure which also caused by respiratory alkalosis. We have some of the important intervention which being a nurse and healthcare provider, it important for us to know about that. And respiratory imbalance, respiratory acidosis, kidney will retain bicarb and excrete hydrogen ion through urine to compensate the process. Being a healthcare provider, we have the responsibility to assist the patient respiratory distress. We have to provide oxygen as prescribed because in the respiratory acidosis the hypoxia is common. We have to keep the head of bed elevated in semipolar position to give space to the lungs to easily inhale and exhale. Encourage the patient to deep breathing to exhale CO2. In respiratory alkalosis, the kidney will excrete bicarb through urine. We have to also assess for the patient respiratory distress. We have to present with the client, provide support, encourage and establish normal breathing pattern. Breathe into the paper bag to re-inhale the CO2 level. We normally use the rebreather mask for the respiratory alkalosis. Monitor calcium and potassium level, which is important for the heart. It is cardioprotective. Prepare calcium gluconate for tetany prevention. We have some causes of metabolic imbalance. First, we will talk about the metabolic acidosis. That is a condition retention of acid or loss of large amount of base. If we talk about the metabolic acidosis, we have the condition of diabetes mellitus and diabetic ketoacidosis. It caused due to severe lack of insulin forces the body to burn fat for fuel instead of glucose. The rapid fat breakdown release massive amount of acidic ketone bodies into the bloodstream. Fatty diet, anorexia, and malnutrition. Without enough carbohydrates for energy, the body enters a state of the starvation metabolism. It breaks down fats for fuel, creating an excess acid ketone that lowers the blood pH. We have also the aspirin overdose. High level of aspirin disrupt the normal cellular energy production and forces the body into anaerobic metabolism. This trigger a toxic buildup lactic acid alongside the acidic drug itself. We have also another condition, we call it acute kidney injury. In acute kidney injury, the damaged kidney lost their ability to filter out daily metabolic waste and hydrogen ion. These acids build up in the bloodstream because the kidney cannot longer excrete them or reabsorb bicarbonate. The last condition, which is diarrhea, intestinal fluid are naturally rich in bicarbonate, which act as in the body primary alkaline buffer. Severe diarrhea flushes this base out of the digestive tract, leaving the remaining blood highly acidic. We have another condition of respiratory alkalosis. Respiratory alkalosis, the patients are hyperventilate, causing the lungs to blow out too much CO2, which acts as an acid in the blood. As CO2 level plummet, the blood pH shift and become excessive alkaline. The first condition, which is diuretic, which cause respiratory alkalosis. Certainly, diuretic force the kidney to excrete a large amount of the sodium, potassium, and chloride. This causes the remaining bicarbonate in the blood to become highly concentrated, while triggering the kidney to excrete acid in exchange for retaining sodium. Severe vomiting, stomach secretion are highly acidic, packed with the HCl. Vomiting expels this acid from the body, leaving behind a surplus of bicarbonate in the bloodstream. Excessive GI suctioning, such as nasogastric or orogastric suctioning, mechanically drain the high acidic fluid directly out of the stomach. Just like vomiting, losing this gastric HCl shifts the body pH into an alkaline state. Excessive bicarbonate ingestion, as we talked earlier, bicarbonate are basic in nature. If we consume too many antacids like baking soda or calcium carbonate, floods the digestive tract and bloodstream with the alkaline vapors. This directly overwhelms the kidney ability to excrete the excess base, rising blood pH. In hyperaldosteronism condition, highly level of the hormone aldosterone force the kidney to retain sodium and dump potassium hydrogen ion into the urine. This continuous loss of these acid ion directly triggers the metabolic alkalosis. We have also some clinical manifestation like we discussed earlier: neurological condition, cardiovascular condition. In metabolic acidosis, neurologic conditions such as headache, confusion, drowsiness, coma, that is common, respiratory condition at rapidly deep respiration such as compensatory cause due to acidic environment. Cardiovascular condition, it decrease the BP, dysrhythmia, hyperkalemia, flash skin, and GI, abdominal pain, nausea, vomiting, diarrhea. These are some of the clinical manifestation of the metabolic acidosis. Some of the clinical manifestation which is related to metabolic alkalosis, such as neurologic drowsiness, confusion, dizziness, and respiratory hypoventilation, GI, nausea, vomiting, anorexia, and cardiovascular tachycardia, dysrhythmia, hypokalemia, and neuromuscular condition, tremors, muscle cramps, tetany, tingling, and seizures. Now, if we talk about the metabolic balances, metabolic acidosis, we have to compensate the hyperventilation. We have to compensate the hyperventilation to exhale CO2. We have to assess the patient for respiratory distress. The most important is to assess the level of consciousness for CNS depression. Seizure precaution, which is also important to prevent the patient from any damage or any fall. Monitor potassium level, which is very important because it also causes cardiac arrest when there is a high potassium level. Potassium level will decrease. We have to keep vigilance on this electrolyte. Metabolic alkalosis, we have to compensate hypoventilation to conserve CO2. The same intervention is required to assess the sign of respiratory distress, monitor potassium and calcium level. Safety precaution is also very important. We have to promote the excretion of bicarbonate through kidney identification and treat the underlying cause. These are some of the normal parameters which every healthcare provider, specifically nurse, should know. The normal pH level, which is in the range of 7.35 to 7.45. Hydrogen ion concentration below the normal level, which is acidotic, and which is increase the normal level, such as 7.45, which is alkalotic. These are the two important parameters such as PaCO2 and bicarbonate level, which help an important role in the maintaining of the pH level. PaCO2, which is the normal range, is 35 to 45 mmHg. Partial pressure of carbon dioxide in the ABGs outside of the normal range indicate hypocapnia or hypercapnia. The name indicate hypo mean decrease and hyper mean high. Capnia mean carbon dioxide. PaCO2, which is the normal range, is 80 to 100 millimeter of mercury. Partial pressure of oxygen in the arterial blood lower than normal indicate hypoxemia. It is unbounded. We have to closely measure when the patient is on the ventilator support or admitted in the ICU. We have another important parameter such as bicarbonate, which is the normal level is 22 to 26 milli equivalent per liter. Depending on the institution practices, in some there is 21 to 28, but commonly the reference range is 22 to 26. Bicarbonate concentration in the plasma, which is the reference range. We have to collect the specimen for ABGs. The first we will look for the patient vital sign. In vital sign, we have to look for the patient respiratory rate, blood pressure, level of we have to the level of consciousness. That is also important. When there is hypercapnia, the patient level of consciousness will be deteriorated. If arterial line in place, obtain blood sample through arterial line, which is an easy procedure in the ICU. But if the patient have no arterial line and we have to perform a specific test, we call it LN test for collateral circulation. We have to also the factors which change the patient pH level, such as suctioning, increase activity, which change the patient CO2 and respiratory rate. How we will perform the assess test? We will perform the LN test. We have to explain the patient that what we are doing. We have to tell the patient that this test is used for the collateral circulation. First, we will make a paste. We will compress the both artery, radial and ulnar. We have to tell the patient to close and open their hand. First, we will open the ulnar. Ulnar, which is the inside, this one. We have to open the ulnar pressure to look for the circulation. If the color is returned to pink, it means that the collateral circulation is fine. Then we will remove the pressure from the radial artery and we will check for the collateral circulation. The normal reference range is less than 3 seconds. If it is more than 3 seconds, it means there is some issue with the collateral circulation. These are the interpretation of the ABGs. First, we will look for the pH, either it goes up or down, acidotic or alkalotic. The second, we will check for either the patient is in respiratory condition or in metabolic condition. We have the important formula, we call it ROM. ROM means respiratory opposite and metabolic equal. What does it mean? If the patient is in the respiratory condition, for example, the patient in the respiratory acidosis, the pH will go down and PCO2 will go up. If we look at the first parameter, if the pH is go up and PaCO2 will go down, the problem is in respiratory. If the pH go down and PaCO2 go up, the problem in respiratory. As we discussed in the above formula, ROM. ROM means respiratory opposite and metabolic equal. In pH and metabolic condition, both the pH and metabolic will go in the same direction. pH will go up and bicarb will go up because the bicarbonate is the basic in nature. If the bicarb level is go down, the pH will also go down. It means metabolic equal. How we will interpret the ABGs is there is compensatory or regulatory system doing their job. If the problem is respiratory, has the bicarbonate work, it increase or decrease. On the basis of that, we call it is fully compensated, partially compensated or uncompensated. What does it mean by fully compensated? For example, a patient has some issue with respiratory. The patient is in respiratory acidosis. As we talked earlier, in respiratory acidosis, it will go opposite. If the pH go down and the PaCO2 will go up. But if we check for the compensation, we will go to another parameter which is bicarb. Either the bicarb is placed on their own range or it go up and down. Either it cause some changing in the pH level. In uncompensated, there will be no compensation. pH is abnormal. ABGs of the compensatory system within the normal range. Interpreting ABGs, it is important for NCLEX point of view that we should know about the normal parameter of the pH. Here in this result, the pH is in 7.45. It is in on the high level and PaCO2 which is 27, it is on the lower range, and bicarbonate is also decreased, and PaCO2 is equal to 54. If we analyze this condition, that we have the normal range of 7.35 to 7.45, the pH here is fall in the normal reference range. Respiratory or metabolic, as we discussed earlier, in Rome formula we say respiratory opposite and metabolic equal. Here it is opposite, PaCO2 level go down and pH is up. Now we check for the compensation. Is the respiratory problem HCO2, HCO3 decrease to compensate for decrease in PaCO2. Less acidic base also decrease compensate. In this condition, the patient bicarb is go down and the patient compensated. In this condition, we call it compensated respiratory alkalosis. Acid base imbalance, goal of care. What is the goal of care? To restore adequate ventilation and gases exchange, which may include oxygen administration through nasal cannula, oxygen mask, or rebreather mask, non-rebreather mask, as we discussed earlier. Bronchodilator, we also use bronchodilator to patient easily exchange their gases. Pulmonary hygiene, positioning head of bed mostly in the semipolar position and breathing pattern in the clear environment we provide to the patient. In the respiratory alkalosis, we have to correct the imbalance and treat the underlying cause. If there is some anxiety, we have to provide anti-anxiety drug, sedative drug, slow breathing technique, use of rebreather mask or paper bag to retain the carbon dioxide. If we look to the metabolic pattern, in metabolic acidosis, treat the underlying cause of the disorder and correct the acid-base imbalance, which may include bicarb administration, rehydration, and antidiarrheal drugs. In metabolic alkalosis, treat the underlying cause in fluid and electrolyte imbalance, which may include fluid electrolyte replacement, such as potassium, calcium, acidifying the solution. We give to the patient to acidify the solution. These are some of the pharmacological management. Pharmacological intervention, we give patient to bronchodilator, anti-inflammatory drug, mucoid drug to improve the ventilation and oxygenation. Antidote to the drugs that may cause acute respiratory acidosis. In respiratory therapy, we have to care in certain conditions such as COPD. In this condition, the patient retain high CO2, evidenced by high CO2 level. Too much oxygen administration will reduce drive and could lead to respiratory arrest. In COPD condition, we provide to the patient minimum flow of oxygen. In ventilatory support may be used in the severe cases. Pulmonary hygiene, which is very important for breathing technique, percussion, and adequate hydration. Monitor to prevent for complication. This is a nursing diagnose. Rest for impaired gas exchanges. Monitor respiratory status and breathing pattern. Repositioning and ambulate as tolerated. Metabolic acidotic intervention, pharmacological intervention such as bicarbonate, which is commonly used in the clinical setting. If serum bicarbonate level are low, carefully monitor for metabolic alkalosis and hypokalemia, which is associated with metabolic acidosis. Potassium shift back into the intracellular space as metabolic acidosis is corrected. Drug specific use may be, for example, insulin in diabetic ketoacidosis. We prevent the patient from the breakdown of the fat and utilize the insulin in this condition. Monitor and prevent complications such as decreased cardiac output, fluid volume excess, and risk for injury due to alteration in mental status. In respiratory alkalosis, we have also important pharmacological intervention. Sedative or anti-anxiety medication may be used to restore the patient normal breathing pattern. Electrolyte replacement therapy if needed. We discussed it in the very detail. Respiratory therapy, slow breathing technique, breathing into a rebreather mask or paper bag to increase inhalation of carbon dioxide. Oxygen may be administered if hypoxia is the underlying cause. Prevent the patient from the fall, which is the key important nursing intervention, and muscle weaknesses. Metabolic alkalosis for intervention for metabolic alkalosis is potassium chloride help to restore sodium level and allow kidney to conserve hydrogen ion. Sodium chloride promote renal excretion of bicarbonate and restore normal serum level. Acidifying solution in severe cases restore normal fluid electrolyte level and treat the underlying cause. Prevent and treat complication if cause any. This is the short summary we have discussed in the very detail of acid bases are maintained in the body by the upper respiratory and renal system. When one of these mechanisms fail, the other mechanism will help to compensate. The respiratory acidosis result from condition causing hypoventilation which lead to build up CO2. Respiratory alkalosis result from condition related to hyperventilation resulting in decreased CO2 level. Metabolic acidosis can occur from variety of conditions that result in net excess of acid reduction and bicarb. Metabolic alkalosis occur when there is a loss of acid or gain of bicarbonate and is accompanied by hypokalemia. The manifestation of severe respiratory and metabolic alkalosis are similar and therefore careful interpretation of ABGs are very important for the diagnosis of the patient. Treatment of the respiratory acid-base imbalance involve respiratory and pharmacological therapy and monitoring of the impaired gases exchange. Treatment of metabolic acid-base imbalance are focused on correcting the cause of the problem and monitor for complication. Thank you so much for giving me this important time to present my view on this important key topic. Thank you.